Okay, I would like to welcome everyone to our April Grand Rounds. And I don't know if I'm the only one who's shocked by it being April, but happy April, and fair warning that it's April Fool's Day if you have people in your household who like to prank. We are extremely excited to welcome Dr. Woods-Jaeger. And prior to doing so, I first want to acknowledge that we here in Seattle are living and working on the traditional land of the first people of Seattle, the Duwamish people, past and present, and we honor with gratitude the land itself and the Duwamish tribe. We do have, in addition to honoring them by acknowledging them, three ways that you could further honor them. One is Real Rent Duwamish, which is directly donating monthly as a rent payment to the tribe. Another is that they have a store with traditional goods. And the third way is that they are currently in a process of trying to get national recognition as a tribe. And there's a petition that can be signed. So, and the website addresses are on your screen. And I would like to invite Dr. Hillary Mead, who many of you know. Actually, I should introduce myself. I'm Dr. Carol Rockhill, and along with Dr. Mindy Manharis are your Grand Rounds planners. And I would like to introduce Dr. Hillary Mead, who is clinical director of outpatient mood and anxiety, to introduce our speaker.
Thanks, Carol. It's my great pleasure to introduce Dr. Briana Woods-Jaeger, who will be presenting on community-partnered approaches to eliminating mental health inequities. Dr. Woods-Jaeger is an assistant professor in the Behavioral, Social, and Health Education Sciences in the Rollins School of Public Health at Emory University. She also holds an adjunct faculty member position in the Department of Community and Behavioral Health at the University of Iowa. Dr. Woods-Jaeger completed her bachelor's at Duke University and her master's and doctorate in child clinical psychology at the University of Washington. She completed practica at our very own Seattle Children's Hospital, as well as Echo Glen, while she was a graduate student at UW. She completed her clinical internship at the University of Illinois at Chicago. So Dr. Woods-Jaeger is by all measures quite an impressive person. She's incredibly productive academically. For example, she's published 46 peer-reviewed papers to date, and she holds 4 active research grants where she's serving as a PI, 2 of which are R01s. She's an award-winning mentor and teacher. She has at least 3 awards in that category, and she also continues to practice as a clinical psychologist. But what I would really like to share with you today is that besides this long list of accolades, and besides being a genuinely kind and generous person, Dr. Woods-Jaeger was exceptional when I knew her as a fellow graduate student at the University of Washington in the Child Clinical Psychology doctoral program. So in that program, in the aughts, in the early 2000s, most faculty and graduate students were focused on research with quantitative methods, ever more complex statistics. So Briana Woods-Jaeger was quite good at that stuff too, but she was also interested in learning about qualitative methods. She wanted to learn about what was being left out when we only use quantitative methods. And you'll see how that seeds of that has blossomed over her career. In graduate school, most of us set out to do research or clinical work in a way that was most convenient for us and likely exacerbated mental health disparities in research and clinical practice. We had research participants and clients come to the university. Briana Woods-Jaeger's interest in community partnerships started at least back in graduate school for her. I remember when she and I were working on a project together, and I found myself leaving the university district. We were meeting with possible community partners in high schools, churches, community mental health centers who were part of the African American community. We are trying to recruit the community to join in an educational experience for the graduate students to learn about how to work with African American community. We received feedback that this really needed to be a real relationship. It needed to be long-term, a mutual exchange, rather than what they had experienced in the past, which was really one-sided. So I felt pretty overwhelmed by this request. As a graduate student, I had so many things to do, but Briana Woods-Jaeger didn't bat an eye. She responded with validation, both verbally and functionally. She offered to partner to write grants with them. And let me be clear, this didn't fulfill any graduate school requirement. It wasn't for her dissertation. It wasn't a course requirement. She was just doing what was needed to repair and build the relationship with the community, which she understood was essential to address mental health inequities. So, Dr. Briana Woods-Jaeger, you were and continue to be an inspiring person. Thank you for being here and sharing your work with us.
Wow, thank you so much, Hillary. That's such a humbling and overwhelming introduction. It like takes me back too. So I really, yeah, thank you for your words and all your partnership over the years. I have learned so much from you as well. So I'm going to try to share my screen real quick so we can launch in. I'm sorry I can't be in person with you all. I love Seattle and I was so fortunate to train and learn so much during my time there. But I'm excited to be with you all today to share a little bit about some of my work focused on community partnered approaches to eliminating mental health inequities. And so I'm going to launch right in. Make sure I'll start by saying I have no relevant financial disclosures. And what I hope to do over the next 50 minutes or so is really present some information for us to analyze different contributors to mental health inequities, particularly among Black and Latinx youth and families. And then talk about some opportunities that we can think about to partner with communities who are experiencing mental health inequities, both in research and practice. I'm going to focus a lot on my our research that has really been focused on intervention development, adaptation. So I'm hoping there will be some applications that people see for both research and practice. First, just to give a general definition of what I'm referring to when I say mental health equity. This is really providing all people fair opportunities to be healthy and attain their full potential by really focusing on removing those unjust barriers to mental health and well-being, particularly experienced by marginalized communities. And that's what I'm going to talk about just to kind of set the stage what some of those barriers are. And then I'll go into some of the ways that we're thinking about addressing them. So my work focuses largely on trauma and traumatic stress. And so when we think about unjust barriers to mental health and well-being, structural racism is a useful framework for us to really think about the scope of the issues. And I know it can be somewhat overwhelming. I appreciate, Hillary, you sharing that reflection. I think that's often the case when we do a lot of this work. It feels very overwhelming because there are so many different facets and contributors. I just want to say from the front, what's helped me with that is partnerships and having colleagues and community partners that are really willing to stay in the work for a long time, because it does take a while. So with structural racism, this is a definition I want to offer. There's many other ones out there, but what I like about this definition is it really emphasizes that there's mutually reinforcing inequitable systems. So that's a lot, right? But I think it's important for us to think about in each of these systems, so like child welfare, criminal justice, education, there's different inequities, and that they are really all reinforcing this disproportionate burden of trauma. Particularly, again, my work focuses on Black and Latinx communities. And it's not only the experience of more trauma or more stress due to certain experiences with the systems, but also that there's really differences in response. And that's a lot of what my work and what I'm going to be talking about today focuses on. And so we need to be thinking about both. And this framework is helpful to come back to because there is always something that we're leaving out. And it's helpful to remind us that there's multiple things that we can be thinking about, as well as multiple opportunities, right? Because there's all of these systems that we can be partnering with to address these issues. So another definition I just want to put out there, and one of the areas where we see the disproportionate burden of trauma is ethnoracial trauma. So this refers to psychological and emotional injury from experiencing discrimination, threats, and violence towards ethnoracial minoritized groups. And it can come in many different forms. I think most folks are familiar with interpersonal interactions or discrimination and harassment. But also there's exclusion based on assumptions of ethno-racial inferiority. This is an important one that I see a lot in my work with schools. as well as when you think about opportunities that are provided or not provided and the way that we allocate resources, kind of going back to that structural racism definition. So this is a really important one to be mindful of, and it's often missed, or you have to really dive a little bit deeper to see it, especially to measure it. And then institutional systemic racism, I think this is definitely more on the forefront now, but hasn't always been. But there's different ways this also manifests. I think, systemic excessive use of police force and also family separation and deportation are two of the areas that we've really focused on. And so all of this, it's not that every youth or family that I work with experiences all of these things, but I have to say, consistently across, and this has been in multiple states with multiple communities, we are hearing different examples of this. And it's related to a lot of mental health inequities in terms of there being, depression, anxiety, and suicidal ideation are associated with it. But also, again, the way that that's responded to is not always taking this into account. And so then that perpetuates an inequity. So just quickly, when we think about mental health care in particular, there's well-documented disparities in mental health treatment for racial and ethnic minoritized youth and families. And this has been over several decades. So we know that there's disparities in access to care, continuity and retention in treatment, the quality of treatment provided, the accuracy of diagnoses. I'm going to talk a lot about, particularly when we look at many of the youth of color that I work with are misdiagnosed with externalizing disorders when trauma is really at the heart of a lot of what we're seeing. And then historical injustices in mental health care that continue to this day. So we have a lot of work to do, but I do want to say what I'm excited to see is we're getting more and more, I think aware of this, but also more and more people are focused on it. So we're having different approaches that we can all learn and pull from to address these. And I think it's important when we think of mental health care to think about again, going back to the multiple systems, to think about how that's perpetuated in different systems. So for example, in child welfare, recent research has found that Black youth are less likely to receive mental health services, particularly for internalizing problems, compared to white youth, even after accounting for mental health needs. So at the same level of need, they're less likely to receive services. In schools, we found this in some of our work, and others have found this as well. The urban African American and Latinx youth are experiencing high rates of traumatic loss and grief that's unacknowledged or not responded to with support, but rather discipline. And so this reflects that we have implicit biases and institutional discrimination in our systems, even when we are doing our best, right? And even when we are trying to practice cultural humility, that there are still things that we need to be mindful of in our systems and work together to think about how we can address these. So racial microaggressions is one of the areas that I focused on for some time. Actually, back at University of Washington, we developed a workshop really to specifically focus on this. Because again, talking about things that can sometimes be missed, because these are brief everyday exchanges, oftentimes they can be more subtle to particularly those who are perpetuating them. I don't think they're very subtle to those that are experiencing them. But they send a message of inferiority. That's sort of like the bottom line, that because of your racial or ethnic identity. And so these are things that we are seeing in clinical settings. And it comes again in a lot of different forms. These are some of the ways that it's been documented in terms of avoidance or minimization of racism. This is one that is common in the work that I do. And where it's just either not recognized as an issue and kind of going back to ethnoracial trauma, that's not assessed, it's not discussed, or it's avoided. So it's seen as like, that may be happening to you, but that's not part of what we're going to do. I can't do anything about that, especially when we think about some of the systems factors. And these are things that we've heard from youth and families that we've worked with. Dismissive or messages about cultural heritage. And these, again, can be very much coming from a place of just being misinformed or not being informed. But again, they communicate a message that their heritage may not be as important or is not important to the treatment process. Colorblindness, this is a big one, I think, because people have an intention of equality when they do this, but it can express to someone that you don't see them or their experience. And then culturally insensitive treatment considerations or recommendations, which is similar to, really not understanding someone's cultural heritage and how that may impact their mental health and the treatment that's provided. So these are commonly experienced, but not commonly discussed. So one study found that 81% of clients report experiencing at least one racial microaggression in the clinical setting. However, 76% report it wasn't discussed. And this results in lower treatment utilization and retention, so we can kind of think about how that goes back to some of those mental health care disparities. So all of this together, presents a lot of opportunities for places that we can focus. And I think, again, going back to thinking about mental health equity, I want to offer that to achieve mental health equity, I think it's really important for us to take approaches both in research and practice that center the needs and strengths of communities that are impacted by these unjust barriers. And so really being able to directly address racism at multiple levels and think about it at multiple levels. It may not be that we always are going to be able to address all of the levels, but taking that into consideration in terms of our approaches and the context that people are living in. As I've said, acknowledging and building on cultural and community strengths. So a lot of the work, because I'm focused on trauma, traumatic stress, it just sort of naturally has a deficit lens. Like when I'm coming in, I have to be really mindful that I'm looking for the strengths in this community. So yes, there's extremely high rates of community violence, but what are the strengths that are also here that we can build on? And then partnering with communities to develop solutions to complex problems. This has been critical to my work, and I think there's so much value when we engage in these partnerships and recognize these are complex issues, and we're going to have to really tap on multiple expertise, including lived experience, in order to address them. So I also think it's important to think about, if we're going to do this partnered work, what are some of the ethics that we really need to be mindful of? I really believe we need equitable partnerships, and that's like I think we all want to do that, but thinking about all the multiple facets that go into it and really making sure that those who are most impacted are at the table. And so that they're a part of the process in our partnership from the beginning, and they can really inform the directions that we're going to move in. Engaging as a learner as well as an expert, and this is where cultural humility, I think, offers us a lot in terms of an approach and a framework. In my experience, communities want our expertise. They're very grateful and appreciative, and they want to be recognized for theirs, right? And that we have a lot to learn and can build on that in our work together. And this is a big one, sustained commitment. So back to what Hillary mentioned. I mean, your introduction kind of covered a lot of it, Hillary, in terms of, when we go into communities and want to do a project or an intervention, that we really figure out how there can be a sustained commitment. And it might not be that we can be that person that's going to be there for the long haul, particularly like as a grad student, we're moving on, things like that. But even beyond that, there's different things that, happen in life. But how are we building capacity and building infrastructure so that it's not going to be just one grant or one project? And then finally, utilizing culturally appropriate theory, research questions, and methods. I get this a lot in the academic spaces that I'm in, that there aren't theories for this, that there aren't frameworks that we can tap into. And I like to let's critically look at that and have people really gone and done the research. And it often might be in journals that you're not used to reading. It may not have been in your training, but to really ask ourselves some of those questions and make sure that we're not kind of just because we don't think it exists, putting a theoretical framework or asking questions that really aren't going to be culturally responsive. Again, I think partnership offers us a lot of opportunity to do this because we can really learn from the community to avoid, using inappropriate theory or questions. So all of this, I think, for me, the way that I've tried to approach this is using community-based participatory research. And this is one definition that I like because I think it highlights some of those key pieces that distinguish CBPR. There's also youth participatory action research. So there's different kind of frames for describing this participatory approach to research. And what I think is so important about it is, again, some of the similar message, recognizing the strengths that each partner brings. But one of the things that is particularly challenging, I think, like as a researcher, I will say, is making sure that the research topic is coming from the community. And the reason this can be challenging is because I have a certain expertise. And so as I go and look at things, I'm just naturally going to be bringing that lens. I need to do the work to make sure that the community has identified this as a priority, particularly the way we're going to look at something. And that if there's a different priority that's outside of my expertise, that I make the connections and bring in others. I've been really fortunate to have colleagues who are really willing to do that and come into certain studies as an expert in an area if that is beyond my expertise. So making sure that research topic is important to the community, that they've identified it as something they want to study. And then the goal of combining knowledge and action to achieve social change. And that requires a lot of balancing different agendas because these are very different things often. And so making sure that we have a partnership where we can be making decisions together about how we're going to pursue that. And these principles on the right just sort of reinforce a lot of, I mean, these are the kind of guiding ones that we use in our work. And often, we fall short. And I want to say that it's not like we are always doing this perfectly, but these are things we keep coming back to hold ourselves accountable, particularly about who owns, the data, who owns like the decisions around the process, how are we sharing responsibility, sharing decision-making. Co-learning, capacity building is huge, and that process of really making sure something sustainable is being put in place. And like I said, balancing research and action. So I think it's important to think about what are the conditions that support CBPR, because you can have a desire to do this, but a lot of our settings aren't set up this way. And so as we go to do this work, it's important to be mindful of this, because I don't think that every project has to be CBPR. And there are times when that may not be possible. And if we try to do it, it can actually do more harm. And so I think it's just important to think about what are some of those conditions. There's many more than what I have listed here, but these are some that I think are really critical, have been for my work, and I know others have documented these. So the first one is really, thinking about what you're driven by. And community empowerment being on that list. So it doesn't have to be the only thing, but really the capacity building is going to be such a part of this work, and the process is going to be such a part that if that's not something that's really that drives you, then it's going to be difficult to sustain. Making sure that you and your team have the necessary skills. And so cultural humility, again, I keep coming back to that, and I'll give a definition of what I mean in a moment, but I think that is really important as a framework, and it offers a lot, it suggests a bunch of different skills that we can use. But I think really thinking about what those skills are going to be for your team to practice cultural humility, and in particular, this willingness to share power and control over decisions. I think this is one of the trickiest places. And it's not like, again, we always get it right, but we're willing, and this is something we're going to keep working towards. Again, I've mentioned being committed to the process, not just the outcome. It's also really important that the community is defining themselves, that they see themselves as a community. So I often come in and I have certain assumptions over who's the community. It's based on probably the literature I've read or my previous experiences, and I need to take the time to get to know that community and make sure I understand how they define themselves. And this will be dynamic. And so over the course, one of my projects we've been doing for 7 years now, and this has shifted. But really making sure that we're checking in about that. And then being open to community participation in the entire process. So not just getting input when it's convenient, which is difficult, again, because there's not a lot of incentives for that, and it takes a lot of time. And so really thinking about how is that going to be built into our process. So with cultural humility, I think there's several different definitions out there. I really like this one by Melanie Turbalon and Jan Murray Garcia, because it also illuminates some key principles. I'm really into these aspirational frameworks. How can we operationalize it? And I think this really offers us some good ground marks, and it helps with accountability. So really being committed to the lifelong learning and critical self-reflection. And I can't emphasize this enough, because it's easy to miss things, especially when you're doing work that feels very urgent and we want to have an urgent response. So really making sure that we've built in processes for critical self-reflection for both the academic and community partner, as a clinician for building this into my process as well. Always having a focus on power and mitigating those imbalances. So they're going to be there. And again, because so much of it is systemic, we're not always going to be able to completely, eliminate them. But what are we doing to mitigate the harm? And then finally, having an eye on institutional accountability. And I know that's longer term work, and that's, systems work, but we need to be we are part of those systems. And so just be thinking about how are we going to ensure there's accountability beyond, again, the project that we're doing. So I'm going to shift now and just talk about some of the projects where we're really trying to bring in this approach and these principles and operationalize them. And we're learning every day, about how to do this work, but just share a little bit about our process and lessons learned. So the first thing I want to talk about is one where we've been doing this now for 6 years, really focused on promoting resilience among African-American youth exposed to community violence. The issue of community violence was identified by the community, and they actually reached out to us and wanted to know, how can we think about really focusing on resilience after exposure? So this project took place in Kansas City, Missouri, in the urban core, as it's called, where there are high rates of community violence. There was a lot of efforts going around prevention, which is really important, of course, But there wasn't a lot of attention to those that are survivors or witnesses or experience victimization in terms of what happens after. And so this was a project the community really wanted us to start thinking about that more. The goal was to identify strategies we could implement across sectors and to develop a community level resilience intervention. So this is how we operationalize that CBPR approach in terms of our steps in this study. So the first thing is we developed our community action board. Youth Ambassadors was our primary community partner. They're an organization in Kansas City who provides opportunities for youth through employment to really develop skills and networks to help them reach their goals. And they had been doing work for a long time in that space and had noticed that many of their youth were struggling with community violence exposure. So they were really eager to be a primary partner in this work. And to do that, they had to join the research team. They wanted to inform every phase and be engaged in every phase. So they completed city training, joined our IRB. And then we did a CAB Undoing Racism training. So we had our entire community action board go through this training to really make sure we had a shared language when we were talking about some of the issues that were going to be impacting even like how we frame our questions. And so this was important. We have youth and adult partners as well as academic partners for us to all be sharing a similar language and also just have kind of a common understanding coming in. So when we think about mitigating power imbalances, one of the ways to do that is to make sure that we're really common terminology, common frameworks, and that we're doing trainings together so that we can really make sure that people can be equitably involved, right? That they can really be informed to be able to contribute and make decisions. And then the biggest thing that the CAB took on initially was survey development. This was a long, tedious task in many ways, where we went through validated scales to see which ones we could use, which ones they did not feel were appropriate, and then we added our additional scales. So this was a lot of work, and I have to say, we had a small stipend for our youth partners to participate, but people really volunteered a lot of their time to this. We then followed up, once our CAB was in place, we did focus groups. I'm going to share a little bit about those in a moment, so I won't spend a lot of time talking about that. After we did the focus groups, we used that to inform our resilience needs assessment survey, where we really wanted to validate our focus group findings and see how they were, some of the themes, how they were experienced more broadly, both with youth and adults. Then did an ongoing data analysis. We're still analyzing much of the quantitative data. We prioritized the qualitative first because we wanted that to inform our quantitative data. And we did member checking throughout, particularly for the qualitative data, to ensure the way we were interpreting our findings was really appropriate. And so that was a process where we did go back and forth with the CAB several times to ensure that we really were interpreting our findings correctly. And then for the quantitative data, to really think about how we were going to disseminate that even beyond the journal article and before that would be published. So I'm just going to give a few highlights of our findings and how they've informed what we're doing now. So in terms of our focus groups, we had 39 African-American youth who had been exposed to community violence that participated. The average age was 16. And you can see here that nearly 40% were living in poverty, and over 70% reported experiencing 4 or more adverse childhood experiences. So in addition to community violence exposure, they'd experienced other traumas and adversities. And at the same time, they were experiencing moderate levels of resilience based on our brief resilience questionnaire, which, it's only 6 items, so it can only give you so much information, but was able to give us a snapshot of sort of where some of the youth in our focus groups were at. And these focus groups generated 2 primary themes. There was a lot of rich discussion, but when we analyzed and really honed in on the areas that we were, again, back to our aims of really wanting to understand their experiences of community violence and what were those barriers and facilitators of resilience, there were 2 primary themes. So the first one was that there were inadequate responses to community violence. This was across the board. All of our focus groups talked about this, and then this came up in multiple areas. So I'm just going to read a couple of these quotes. The first one I think is really important because we had been focused on really thinking about over-policing and thinking about police violence, and that did come up, which I'll share in the next theme. But something that wasn't as much on our radar was this idea of how youth perceive police and safety. And so this one participant shared, at first, police don't even be there on time. A little boy died because the police canceled or hung up the phone, like they don't get there early enough. And then there were multiple, once this was shared, multiple other stories and experiences that you shared about this feeling that there wasn't anyone there really prioritizing safety and immediately responding to crises. Another theme that came up is that there was just a lack of action. So people were talking a lot, and there were signs up at school, and there were things, different initiatives coming from like the mayor, but there wasn't a lot of action youth were seeing, and particularly around mental health. So this quote, "We really don't have no places that can help. It's always like somebody that's going to die in the beginning of the school year. Everybody really ain't going to know how to cope about it." So sort of this acceptance, this is going to keep happening, and there isn't going to be an adequate response. Youth also were very aware of their physical environment and how that contributed or detracted from resilience. And so this last quote really reflecting what they noticed about the differences in their environment and others, and how that contributed as a barrier to resilience. So this became one of the primary areas that youth were really highlighting for us to focus on. How can we shift that and have more responses to community violence? The other theme was experiences of racial discrimination. And again, this was across our focus groups, and also the way they described it was across different settings that they were interacting in. So as I mentioned, police violence did come up. There's not a law that says it's okay to kill a Black man in a car, but we see all these white cops killing Black men, and it's okay. And a lot of what participants shared, kind of similar to this quote, was really that not only is it happening, but again, there's no accountability or there's no response to it. So this, again, the sort of lack of there being any kind of response, that people are really invested in making this better. They also shared about feeling harassed in the community and in their schools. So one participant shared, "And that kind of irritates me when I want to go somewhere and the police is just all up on me, like trying to see what I'm doing. I just came to chill and have a good time like everybody else is doing, and I'm the one that's getting stopped, and I'm the one that's getting questioned, and I don't have nothing to do with it." So this feeling and the hypervigilance that would result because they felt they were always being monitored with from a negative perspective and being perceived as a threat. And then this last quote reflects that happening in the schools as well. So all of this really presented many different areas for us to focus on. And youth, we had a section where we asked them to prioritize, what they wanted in terms of strategies and recommended actions, and we got a lot. So we have a blueprint now, of really where we should be focusing. And you can see that many of these were across the focus groups. The biggest one, and this is also the biggest one to take on, is really mitigating racism and discrimination across all of the sectors we were focused on. And again, that was healthcare, criminal justice, education. And so thinking about how are we going to be involved in addressing this, promoting an increase in mental health resources in the community, really having more responsive approaches into bullying and violence within the schools. So really, youth saw schools as a primary location for us to be focused on. One focus group talked a lot about churches. It wasn't one of the themes that happened across our focus groups. You'll see it was just one, but they spent the majority of the focus group focused on this. So we wanted to make sure it was on our recommended actions. And then investing in neighborhoods, building community infrastructure, and holding police and law enforcement accountable. So this is a lot. And one of the things that was really important for us was to think about how do we prioritize, keep all of this on the agenda, but where are we going to start? And I'll talk a little bit in a moment about how we got there. One of the processes with this was to take those focus group findings and then again do a larger quantitative survey to really see how is this validated or translating kind of on a larger level. So this is just our one pager that we had at our community forum, which I'll talk a little bit about in a moment. But one of the things I wanted to highlight there, and we spent a lot of time about what do you put in one page, because our survey had a lot in there and we learned a lot. And that's where our CAB guided us on some of the things they really wanted to be out there for the community. And one of the things was, again, really sort of shifting our framework to think about, yes, we want to prevent community violence, but there's a huge need to support those that have been exposed, with 67% losing a family member or a friend to homicide or violence. And traumatic grief in general, loss was not in any of the conversations that were being had kind of on the larger level with community violence at that time. Also, the high number of ACEs that were experienced by youth. So they have this accumulation of traumas and adversities that they're dealing with. There's some issues around access, as you can see, in terms of both physical and mental health. And then really some of the risk and protective factors that the CAB wanted to highlight were protective, like this issue about grit and resilience. They wanted that to be on there and to think about like how youth were perceiving that in themselves and how adults rated that in youth that they work with. But also the microaggressions and the language they use, racism in school, they wanted us to really measure that and start to think about starting to have that conversation more broadly in the community. So in relation to that, we've done, again, we're continuing to analyze that data, but one of our first and this was informed by the CAB, one of the first things we looked at was this relationship between, in the focus group, we heard that schools were really important, that racism was happening in schools, and that was hindering resilience. And so we wanted to understand this quantitatively. So one of our first analyses was to look at the relationship between ACEs, racial microaggressions in schools, and resilience among African-American youth exposed to community violence. I've already talked a little bit about some of our methods, so I'm not going to spend a lot of time on that. I do want to highlight that really both the recruitment and the location for our survey was completely because of our CAB and their networks, and that the survey was co-developed. And so that again, we had a mixture of validated scales that we were using, as well as particularly for the strategies. That was where we spend the most of our time developing it based on what was already happening in the community and also things that they felt were gaps. For this particular study, we didn't focus on the strategy. We were just looking at these relationships between ACEs, microaggressions, and resilience. Our youth, this is just our youth portion of the survey. You can see kind of similar to our focus groups in terms of age. We did have a pretty balanced breakdown between gender identity. Our ACE score continued, and this is continued in other studies we've done, it's very high. And then in terms of microaggressions, it's on a range from 0 to 3. So, you could say this is extremely high, but they are being experienced. And part of what we looked at, as you'll see in our moderation analyses, was how is it affecting resilience for those that did experience it at a higher level. So what was interesting with this, there was a few things. One is that there's different categories of the microaggressions. The academic inferiority and the stereotypical misrepresentation, those microaggressions, experiences at higher levels of those, amplified the negative impact of ACEs on resilience. And so this basically validated what youth were saying in the focus group. These particular experiences were seen as a hindrance to them being resilient after violence exposure. But then when we looked at it also, you see that low levels, it was not associated. And so part of what that told us is it's not so much that the absence is like that we're going to think of that as like a protective factor, but that we really have to focus on for those that experience it, how are we addressing that as a stressor on top of their violence exposure? So we took all of our data that we had analyzed at that time and had a community forum. And this was really an opportunity for us to bring the community in a larger way to figure out how are we going to prioritize and translate this research to action. And so this was all youth planned, and they, from the guest list, identifying particularly our youth leader stakeholders that really came from our youth CAB members, all the way through the way that we invited people, social media, that they're much more well-versed in that. And so I really wanted, the investment from our youth leaders was tremendous. Went way beyond a job. And we were really excited with who came. So we had the mayor, we had the school superintendent, police. We had several police members who were requested to come not in their uniform, and they did that. And we had really rich discussions. And one of the things that came out of it was that we were looking at both what is feasible for us to get started with right away and what's important. And increasing access to mental health services was identified as that top priority where we could start. I want to say that also addressing racism, particularly in law enforcement, was on that list. Folks felt like that was going to be a much longer and arduous path. And so wanted to really emphasize starting with the mental health access. So I just want to emphasize how critical this process was, because you have all this data and it's really hard and it can be very overwhelming to think about where we're going to move next. And so this forum really helped us bring more of the community, including those leaders and stakeholders that were going to be able to sustain these efforts into the decision making. So I just want to share a brief clip, hopefully this will work, we have a video for this project that we used just so the community would know what we were doing. And this clip is just some of our youth leaders speaking. I wanted to make sure you could hear their voice. So I want to play, it's just about 1.5 minutes.
Youth Ambassadors gives kids a chance, like 14 and up, to get off the streets before something bad strikes their attention. And then they get into that, and then it's probably too late to get them up out of there.
And it gives them that feeling of security that someone's actually proud of them.
If I never went to Youth Ambassadors, I don't know what I would be doing, to be honest.
They really are listening to you, and that's basically what the program is for. It's so you can thrive and you can get over and conquer all the obstacles in your way.
The demographic we work with at Youth Ambassadors, the urban core teenager, is a demographic that most people want to shy away from. And our project is youth informed. And they are the ones leading the project. It's through their voice that we are coming to our results.
I never thought of beforehand the statistics and how many other youth are going through something so similar. By learning that and being a part of the cab and knowing that I'm actually putting my foot forward and doing something that's going to affect the youth, and not just the youth, the adults and the community as a whole, I feel like I've grown so much to where I'm stronger now.
So again, that's just a snippet, but I wanted you to hear some from our youth leaders. I think what they really speak to is our community partner as well, and how valuable for the whole process, but also for sustaining our efforts, our community partner is. But also really what was interesting to me in their reflections was a lot of times, again, I'm worried about that deficit approach and that we're so emphasizing, stats that are very discouraging often. But there was a lot of talk about how it helped people that are struggling with this already to realize they're not alone, and then to see people actually taking action was really powerful. So again, the process of doing all of this is also really important in addition to the results. So right now we are in our pilot phase. So based on the findings, we then went into a process of really identifying what intervention we wanted to disseminate more broadly in the community. And we selected SPARKS, which is structured psychotherapy for adolescents responding to chronic stress. It's a mouthful. It's an evidence-based intervention for traumatic stress. And we selected this one because it's designed for youth who are still navigating contexts of trauma and stress. And that, as you saw with the high ACE scores and what youth were expressing, that was exactly the population we were working with. It incorporates it's a skills-based approach. We chose the ST version, which is the shorter version. That, again, was feedback from our CAB that we really wanted to think about what was going to be feasible to disseminate on a larger scale. And we adapted this to address racial trauma, building on cultural strengths, using that formative data that I shared. So in this curriculum, we have video vignettes or videos that we use to really describe, like, how are you going to use the skills and get people to engage with that. Those are focused on different racial traumas that we heard. So police violence is one of them, microaggressions happening in schools. So we're really taking what we're hearing and thinking about how do we apply skills to deal with these issues that have been illuminated that are particularly relevant. And we're also looking at how, again, thinking about access, what models and approaches can we take to get this out more broadly. So we've adopted a task sharing model, which we're currently studying, where we have clinicians paired with lay mental health providers delivering these groups, and they're delivering them through community-based organizations and school-based health centers. Currently, those are our, we hope to get into churches as well at some point. And so the goal with this is to really, again, test this as both a model, and we're looking at the intervention itself to see if this is going to address those mental health needs that were being unmet. In addition, we have caregiver workshops that we have developed where we teach essentially many of the skills. We actually go over all of them, but we hone in particularly on ones that caregivers can use kind of more on that day-to-day basis with the youth that they're working with, in order to build capacity of teachers, parents, faith leaders, different folks in their lives to be able to reinforce these skills, have the same language, and to be able to offer them in those moments of high escalation. So we are currently following an iterative intervention development approach with this, where we've adapted the intervention based on that formative work I described. We're in our preliminary test phase where we basically have 3 cohorts to go through it at a time, and we collect data throughout the entire process, analyze that, make iterations, and continue until we reach a point where we are pretty much settled on our intervention. There's not a lot of recommendations for improvement, and we're ready to then do our pilot RCT. So I just wanted to share a little bit about our first, we're in our, now going to our second round of cohorts. So our first 3 cohorts, just to like a snapshot of where they're at baseline. And I think just the important piece here, again, sort of echoing what we've seen before, but that definitely this is a need, and that this intervention, in terms of it being a fit for the community, we see high ACE scores, but also high levels of depression and PTSD symptoms. And so, we feel like we are responding to that in terms of the intervention selection. And now it's, once we do the RCT, obviously wanting to make sure these outcomes change. We also, as I mentioned, after every group we do an interview with all of our participants. So some of the things that we've heard is that they are feeling that the content is relevant. They like the way that it's delivered in this group in the skills format. You can take it into your real life. We were really excited to hear that several of them are sharing that with their other youth. So they're taking it out of the group, you know, like this person who shared that she's sharing it with her cousin. So really being able, that to us communicates it's relevant, and also that youth feel empowered to share it. And that one of the things that was really important from this first round that we've heard is that one of the things bringing youth to the group is the opportunity to think about their future. And we hadn't really thought about that, and making sure, you know, how valuable having a space for that would be, especially if you're living in an environment where there is chronic stress. So this was really helpful for thinking about making sure that we really have that as a priority for what this space can be. And fortunately, the curriculum very much fits with that. But that was something that was really important feedback. In terms of the delivery, the biggest thing we're hearing is that people really like the lay mental health provider, and that, you know, they relate to them. It's inspirational for them to have someone with the same lived experience, and they're co-teaching these skills to them. Our lay mental health providers are able to really talk about using them in the daily experiences in a way that me as a clinician not in that environment cannot. And so this has been really well received so far in terms of that model of delivery. And so far in terms of we have that balance where we have the clinician there too, and we have consultation meetings after every group. Everything's being delivered with fidelity. So it hasn't changed the delivery quality, and it's really been an enhancement from what we've seen so far. This is all very preliminary, I should say. And then for the workshops, we just finished those. And so we've had 39 adult caregivers who've been trained so far. They're 6-hour workshops, so they are quite a commitment. And we do them over 2 days. And what's exciting is they are, the caregivers are reporting that they're sharing these with youth. And so 85 youth have been taught skills from Sparks by community trained caregiver. We're going to be really excited once we get the data in around how it's impacting the youth that have been taught these skills. But we're really excited to see this, again, when we think about access, that we are meeting those goals of greater reach. All right, so I'm going to monitor my time. Okay, so I'm going to talk just a little bit then about another study that we're doing and focused on, and it really came from COVID, focused on how are undocumented Latinx immigrant families being impacted, particularly psychosocial impact. And so I want to say this study really came again from our community partners. So I'll talk a little bit about them in a moment. So first, I'll just kind of highlight, we're really looking at the impact between COVID-related stressors and parent depression and PTSD among undocumented Latinx families here in Georgia. And wanted to have an emphasis on looking at some of those structural risk factors as well as community protective factors, and how we can engage more of the community protective factors to reduce some of the structural risk. So those were the goals of this pilot study. And Surf Familia is our community partner, and we had been working together. Surf Familia actually approached me a couple years prior to or maybe about a year and a half prior to the pandemic, about they were really interested in doing more work with ACEs. And so again, this has made it easier in terms of that whole piece of the research, identifying the topic that folks have come. And I think part of what I can talk about was help, but being in spaces where community is really helpful for that. So we connected around that, and we're sort of developing ideas that we wanted to study. And then the pandemic hit, and Surf Familia felt very strongly that the undocumented Latinx community here in Georgia was being missed in terms of even on the radar. And so wanted to do a study to really highlight some of the needs and what we needed to be focused on during the pandemic. I want to emphasize, so Surf Familia is on the front lines, continues to be, but during the pandemic, because the undocumented Latinx community here was not receiving federal, support, wasn't receiving local support. They had to come and fill that need. So they're out there on the front lines doing emergency food assistance, providing social services, doing a lot of mutual aid with other organizations. And even in the midst of that, wanted to be active in the entire research study and felt that they had to be, which I completely agree with, in order for us to reach this population. So they did city training, they joined our IRB, and then they went through training with us to learn how to recruit, consent, and administer this survey. And it's tremendous, the commitment that they have, and that's what's made this partnership so successful. So we had a goal of reaching 150 participants during the pandemic. And undocumented Latinx families, so a population that is often difficult, especially as an academic researcher, for me to come in and engage, to ask these types of questions. We're asking about trauma, we're asking about family, things that are very important and sensitive. And so Surf Familia enabled that to happen completely. And we trained them in the survey, we gave them materials and equipment, they conducted them. They were on a tablet and papers, so they had those materials, but we had to do a lot of, during our weekly meetings, there was a lot of problem solving for things that were coming up. After the survey, the Emory team did interviews with frontline workers, and that was conducted by us. We have a tremendous bilingual, bicultural team where we were conducting the interviews in Spanish and English based on the preference of the participant. And really it helped us contextualize our survey findings because the frontline workers work with multiple families. So we're able to get that quantitative data from families to kind of see what are some of the areas we need to be focused on. And then we contextualize that with what frontline workers were seeing. And again, same sort of ongoing data analysis process. We started, this time the quantitative was first, and again, contextualize that with our qualitative data. And just for time, I'm going to move kind of quickly. So this is just to show some of the characteristics of our sample. So majority female identified as female and married or living with a partner. You can see, again, we have a high percentage that were living in poverty, uninsured, and about average age of 40 with 3 children, 2 that were born in the US. And so in terms of, again, focusing us on what the needs, extremely high in terms of our screeners, high rates of PTSD and depression symptoms among the adults in our sample. And then in terms of the stressors that were identified, these were pulled from initially CDC had like a bank of questions that you could ask and include in your studies and evaluations around different COVID stressors. And so we pulled from that. And as you can see, the sample was experiencing a high number of particularly the ones around economic factors. They also had many protective factors. And so you can see participants, on average, they rated 3 as protective factors that they experienced. And you can see here a range. So that emergency aid was critical. I mean, basic needs, I would say it is a protective factor, but it's a basic need. Like it's unfortunate that has to be kind of a addition, but that was something that was rated very highly. Also relying on spiritual beliefs, family and friend support, and having access to culturally responsive services. I do want to note this was a convenient sample of Surf Familia clients, so they had access largely through Surf Familia. If and when we do our larger survey in Georgia, I don't know that we'll see this high of a rate from some of the things that we've heard. So in terms of structural risk factor, we looked at perceived immigration policy effects, and this is a scale that really allows us to see how immigration policy is being perceived and affecting families. And so this is the adult scale. There actually has now been adapted to it. There's a youth scale, which we're going to be using in another study. But what you can see here is that participants were rating high levels of feeling threat to their families, so concern for family safety or fear of family separation, as well as high child vulnerability. Concerns for, and I'm going to share just a little bit of our qualitative data too. You'll see this come through that as well. I'm just looking at some associations. So again, helping us sort of figure out where do we want to prioritize. Something that was really illuminating and surprising for us was that COVID-related stressors were not as significantly associated with depressive symptoms. Perceived immigration policy effects were. So we weren't surprised that perceived immigration policy effects were, but we were surprised that I mean, really, even in the midst of COVID, that was more of the priority, and that was really important information for us. We saw the same pattern with PTSD symptoms, and so that's really helped us, again, focus on where we're going to put our energy and prioritize in our next steps. So then just some of the qualitative data around this, and you'll see it really, it does provide further context, but is very much validating what we saw in the survey. So one frontline worker shared with us, the fact that clients go out to work during the day and it creates a tension, it even generates a trauma, a PTSD, because they see a patrol car behind them and they start to shake, to sweat, and to say, now they're going to stop me now. They're going to deport me. What will happen to my children? And I think there's so much important in this quote, but one of the things that we heard, and you'll see it in the other one as well, is this deep concern for their children and the fear and anxiety around their children being taken care of, what's going to happen if they are not there. So as another participant shared, yes, the political climate is another situation that we face with our clients because a lot of them can't attend every program that is offered in the afternoon because they're scared of being detained by the police and being deported. It's the fear of being arrested that they are deported and having to leave their children here well alone without any resources, and they remain completely alone. So again, you hear that theme of the fear of family separation or child vulnerability coming through in the qualitative data. And also what's really important for us in this quote and was reflected in others is that when we think about our intervention, to make it accessible, we have to go beyond even Surf Familia. because many folks did not feel comfortable accessing services or supports there because the routes they would have to take, there were stops. Police stops that were set up just waiting for folks to come through. And so this was something really illuminating for us. And as we think about the model of delivery is really important. And I should have highlighted, I don't know if I said this at the beginning, these are themes and representative quotes. So these quotes represent several folks that have shared the same thing. And so I don't know if I mentioned that when I first presented the themes. So the other theme that we heard was there was pandemic related stress. So even though we didn't see the expected hypothesized relationships to our mental health outcomes, I want to caveat, we had a small sample, but we did see that it was something that was compounding other stressors. And so this first quote, "It has increased due to the pandemic because of the time that we have to live together and the entire family under anxiety and nervous tension of how am I going to pay the bills? Turns out I don't have a job. They have laid me off from work. Perhaps I have a light bill and the entire family had to be on lockdown and the entire family was infected." So the compounding stress that families were dealing with. And then another participant shared, "So a lot of people told me that they felt that everyone could not receive help. Or for example, a lot of people can't apply for unemployment insurance because they don't have a legal migration status and that economic aspect. But their children need to eat and they can get evicted from their apartment and they don't have money to buy food for their children. So of course it has generated a lot of stress for them." So again, this real concern for children not being cared for and some of those immigration related policies, how that's impacting families during the pandemic. So in terms of our next steps, we are very much in the early phases. So we have just identified the approach that we want to take, and we're looking at a multi-level intervention that involves a promotor-delivered attachment-based intervention that was developed by one of my colleagues at the University of California, Irvine. She's been doing this with Latina mothers for some time and has really good outcomes on parent mental health. And one of the reasons we chose this attachment-based intervention was because of the fears around separation, the fears of not being able to take care of their children. This intervention directly targets that and actually offers a strength-based approach to targeting that. And again, it was developed and has been tested in this another community, but with Latinx families. We're using a promotor model so that we can go into the home so people do not have to come into the clinic because of those barriers that were identified. And in addition, having a community organizing level of the intervention, really thinking about a lot of things that we heard too was there's this isolation, feeling that you're alone, that nobody cares about these issues. Again, Sir Familia's top priority was putting this on people's radar. That's why they wanted to do this study, and it's really informed our dissemination plan. And so starting to really think about how that can be an intervention for mental health. And we're going to be looking specifically at PTSD and depression, as we saw that was very high, and mixed status Latinx families. So I think, I think I'm actually on time. I just wanted to end with a few takeaways and then I look forward to questions and discussion. I think, one thing that's just been really important for this community partnered work, we're addressing complex problems and it's dynamic in terms of as we do the work and we continue to pilot these interventions, more things emerge related to the mental health inequities that we're focused on. And so it's been so critical to have multiple expertise at the table. So we have, I'm very fortunate to have the opportunity to work with incredible researchers and clinicians. And then, like I said, I can't say enough for the lived experience and expertise that really is in terms of our community partners. So that's been something that to prioritize that has been critical. And I think that allows us to think more complexly and really address things with more of both a multifactorial, but like really thinking about things in a more complex way. And then community assessment and capacity building activities that have led us to like our interventions and the way that we, implement them takes a lot of time. And as you can see, we started the first study, it has been 6 years. So it does take a lot of time, and I know it's not always possible for everyone. We've been really fortunate with the supports that we've had for doing this, but I think it's critical to ensure sustainability. So for example, our funding has ended for all of the work I talked about, actually in both of these studies. And everything that we are doing is continuing to be sustained by our partnership and by the fact that capacity has been built for our community partners to deliver many of the interventions. So I think this is really important when we think about how can we ensure, and again, I think that's an ethical issue, the sustainability of our work. So just want to acknowledge again, we're very fortunate that we have been funded and that several folks are willing to do this iterative pilot intervention sort of process and support it with us. And so I want to acknowledge our funders as well as our CABs. I didn't really get a chance to talk about our Thrive CAB, but we have 2 tremendous community action boards that have been critical. I mean, they're the heart of this work, and happy to take any questions or comments.
Wow, awesome. I'm even getting texts and emails saying how amazing this is that are outside the chat. So that really speaks to how impressed people are with your talk and all the information you're sharing with us. And yeah, I think there are some good questions and discussion points that we can tackle. So for those of you who maybe don't attend regularly, just so that you know, if you want to put questions in the chat, that would be great. And then I will kind of moderate our discussion. We do have a few questions we can start off with. And then if we don't have more, we could also open it up to people to unmute, but we try to kind of moderate because it's a large group. I think we have over 150 participants today. So there's a couple nice questions that have been posed. So let's start off with those. One of them that maybe we could start with is somebody mentioned, when you're working with these families and when you're partnering with these communities, there are a lot of opportunities where you may learn about current exposure to violence or current trauma that's happening, in the focus groups and whatnot. And so the question is about how do you respond to that in the moment if you know that there is ongoing risk?
Yeah, that's a great question. So the way that we've done that, and again, this is where the partnerships are so vital, is before we start the study, and part of that pre-work that we're doing is identifying the resources that we are able to provide feasible, that are actually accessible, and making sure that we do have that in place, because that's definitely a concern that we have seen. And interestingly enough, the focus groups, they're not meant to be an intervention, but we've heard a lot about just that process actually being quite healing for folks. But for many, it also has brought up, this is even like recognizing that this is a trauma or how it's impacted them, as you talk more. And so it's been really critical that we have a resource list that we know is vetted, that we can do the warm handoff if needed. So yeah, that's been critical.
Yeah, it makes a lot of sense. It seems like you would have a high likelihood of learning about concerning, circumstances in the types of communities that you're working in. Something that I was interested in, a question I wrote down that's from myself as you were talking, is I'm really interested in the way that you used kind of the lay mental health providers. And I was wondering if you could just talk a little bit more both about, the content of the training, but also the extent to which you feel like they needed to be part of a team that involved a more trained clinician, or whether, on their own, they, had significant impact. And I think, I partially have this question because I think about like all the rural parts of our state and the areas that are underserved, where being able to use, lay providers would just increase access. But I also think about it in the sense of the fact that if those people are from the communities you're serving, they're more likely to connect with the people that they're serving in more authentic ways and so on. So I wonder if you could talk a little bit more about that.
Yeah, so I completely agree with what you shared in terms of both access and the engagement that happens with lay mental health providers. And I see Shannon Dorsey's on, and I learned a lot of this from her and the projects that she has globally, using lay providers to deliver evidence-based trauma interventions. And I think one of the things I learned from that, being able to be a part of some of the qualitative work, was how much expertise they have. Once they get, training and consultation is critical. So you do have to have those supports in place. But also just the way that they're able to naturally be culturally responsive, right? And to just you don't train that. And that's something that actually is hard to train some clinicians in, right? And so being able to have that partnership, I think, is so powerful. And I do think that they can do it without the clinician. Our community partners wanted to start with that model because they had a lot of concern about exactly what you brought up. What if because there's such unmet mental health need, they were worried about things way beyond trauma coming up. So they wanted to make sure that we had a clinician accessible in the moment to respond to that. However, I agree. I mean, I was wanting us to kind of move more into having the lay providers with consultation and supervision where they could access the clinician, you know, whenever they needed them, but didn't have to have them like right in the group. And that's part of what we're gonna, as we pilot, you know, we'll continue that conversation, because I do think one of the things we're finding, particularly as we think about scale, is there's only so many clinicians trained in Sparks themselves, you know, able to do the groups together. And there's an increasing demand now that lay providers, you know, and the networks are learning about it. So I think that's definitely an important thing that we're going to have to navigate.
Yeah, for sure. Shannon, do you want to unmute and maybe just ask because you have a question and a comment, and I know you're very familiar with this work. Do you want to just kind of join in the discussion and ask your question?
Sure. And I've learned so much from Briana. I feel like I have 12 questions I want to ask, but I'm trying to not take up all the time. So yeah, I mean, some of it already just came up from Mindy's question, but so some of my comments and you know, about how they work together and collaborate, I did wonder, are there places when you saw them work together that when they work together, more distance is created because the clinician is in the room and it's not just the youth lead? Or are there places that, you know, you think we could learn from? We had a call with the state just yesterday about some of these aspects and how to capitalize on youth and peer leadership and BA level and what the role is of the clinician. And clearly there's probably strengths, but also problems when they're together. So if you have any advice or thoughts, lessons learned.
Yeah, no, I definitely agree. I think there's strengths and challenges. In terms of one of the strengths that I've seen, so again, sort of my bias, or I was leaning to like lay providers should just, you know, they should do it. They get it the best. They're going to be able to like translate it the best and engage, you know, our youth the best. But what we found was because lay providers have the lived experience and can really, I think, process in a really deep way, which is a good thing. But in our group setting, you know, we have an hour, maybe an hour, 15 minutes. And we're also trying to, you know, have fidelity to the skills, making sure that everyone gets the adequate dose, because that's always a challenge too. Like, yeah, so anyway, just because of some of the limitations around time. So what we've actually seen that's worked well is our lay providers will take the lead, particularly around talking about racial trauma. So that is, I think, something, and even when I'm doing it and I can speak to, you know, my experiences, there's a difference, right? And so, and I'm not living in the same neighborhoods. And so they take the lead in those discussions, and then the clinician can come in and sort of make sure the skills are infused in that discussion so it doesn't become a process group, because that's been kind of, there has been a pull to that. And I think, you know, one might say we need to have a process group too, right? And that's probably what we're seeing. As you saw, you know, and what we're hearing is that the youth participants love the skills and they feel like they're super relevant and they're engaging with them, they're sharing them with their networks. And we always run out of time, and particularly around racial trauma, there is a lot that folks want to discuss. And so, so that it's been a strength, but also I think a challenge to figure out what we prioritize, which is always, I think that's my like constant challenge in life, you know, but in research and all these complex problems, right, is what to prioritize. I think the other challenge has been, as we look to scale, is finding both a number of clinicians, but ones that are willing to do this. We have talked to some that have some concern about, I think it's like role confusion and, you know, like the dual roles things, you know, things that, and, you know, I get that those are definitely things we need to think through, but I think that creates some barriers in terms of who wants to do this, or not even wants to do it, but who feels like this is a role they can take on long-term. And so that's another thing that I'm challenged by, is as we think about, you know, doing these great pilots, that we're always thinking about scale and like what's going to make sure that we can actually, because we're investing so much, right, in doing this and studying it, that we can really scale it. So those have been some of the initial things that we've encountered.
Thank you. Those are super helpful, even just in work we're doing now. So I appreciate you sharing those.
Yeah.
Yeah, I was wondering about the process versus the skill-based kind of aspect of how you know, how you would do that as well, and how you might sort of structure your groups accordingly going forward, or, you know, structure alternating or having some process versus skill-based. I mean, I could really see the importance of both of those, you know, both of those components. Kind of on a slightly different, you know, thread. There's a question about what, when you're kind of approaching community partners at the outset, before you have the relationship with them, what are some strategies, that you think are helpful for how you engage them at that stage? So, that's the point where you want to avoid coming across as like being from the ivory tower, and you want to convey to them that you're trying to partner and the approach you're trying to take. And what are some strategies that you might use early on in that stage when they don't know you yet?
Yeah, I think one of the things that was helpful for me, so I moved during between the first project and the second one, and as I go into a new community, so here in Atlanta, a lot of what I did that first year, thankfully before the pandemic, was just going out into community spaces where they were talking. I mean, so ACEs was a big discussion that was happening here, and there were coalitions and collaboratives forming. So I would go into those spaces really just to learn. And my objective was to meet people, to learn what was happening. And in those spaces, I mean, I was sort of fortunate they were set up to have, conversation afterwards, and people were really willing to talk. But I think one of the things that was unique was I would always introduce, that the approach that I was going to use, I would make sure to talk about that. Because I think that will just attract certain people that want to engage in that process too, right? And again, like I said, it's not always, I don't think CBPR has to be every study, but I think, so I would look for opportunities where I could talk a little bit about the work that we were interested in doing, what we had done before. But to build a relationship and to build the trust, I think time is the biggest thing, and being able to show up in different spaces that are not academic spaces. And sometimes, those opportunities are hard. We have been trying to cultivate some relationships with some other organizations, and with the pandemic and everything, we just haven't been able to be out there. And I will say recruitment on those projects is much harder. I think trust is just such a, even though I will say people are really willing to partner or to engage, but to really do the full work, particularly around the topics we're focused on, looking for opportunities to build that trust. And the feedback that I've gotten, what builds that trust, I guess you asked about strategies, is that I am willing to do things that have no academic benefit, right? I mean, I always am learning, so they're always beneficial. But I'm willing to do trainings for free for the organization. I'm willing to look at their conferences. So the Surf Familia, that study I talked about, one of the things that was really important was that I was presenting, they organize a summit every year. I go and present at their summit, we have dialogue there. I'm willing to be a resource for other things that they might be working on, if they want to, grant writing, things that our community organizations are often tasked with, but don't always have the resources, and that's something we can share. So those types of things, using the skill set I do have. So it's not a lot of work for me. I mean, it is time, but it's stuff I'm already doing, and then how can I offer that? So that's one thing I think, because a lot of times people are very overwhelmed by how can I offer anything to the community? And I think there's so many things that we can offer just from our our own training and experiences. So those things have worked well, and then they're willing to do the same thing, right? So they come guest lecture in my class, and they, so it's very mutual. And that's worked really well. And I think by me inviting them, even though it's time and work for them, I think they get to see that I really do value them as experts. They're not just where I'm going to go recruit, right? And so I think that's also really helped build that trust and mutual understanding.
Yeah, those are really helpful
I
suggestions.
guess the other thing I'll say is that I try to be, although it's hard with the whole critical self-reflection, but I try to be really transparent about when I fall short, or when the systems I'm a part of fall short, and we have had those instances. So when there's a breach in trust, I immediately take ownership of that, which is hard. And I'm really fortunate that I have supportive colleagues that can kind of help me with that, because those are setbacks that are hard. But I think that's also helped, because it's we all make mistakes, right? And we all are navigating complex systems. And so being able to have those conversations really openly, I think they have appreciated that as well.
Yeah, definitely. Definitely. Wow, so much good information. Are there other questions? There are some comments in the chat, so those might be just of interest to you, or we can also send them to you afterwards. But are there other questions that people have? We have about 5 more minutes or so. And I think I've gotten most of the questions from the chat. If anybody wants to either unmute or put another question in the chat, we have the privilege of this expertise for another few minutes. I feel like we should maximize it.
I'm happy to ask a question. First, I'll start by Briana. It's awesome to see you, and thank you very much for this talk. my question is, we've done some CBPR work, and as a outside provider coming into a Native American community doing substance use work, what we found sometimes actually is having an outsider come into a group where they felt like you got them and heard them in some ways actually was a useful thing. They didn't always want to talk to people within their own community because there was worry, especially around substance use, stigma around substance use, and communities can be very tight. So I didn't know if you'd also experienced maybe the pros of having an outsider come in, or like you were saying, kind of that double jointed connection between someone from the community as well as someone outside, and that was seen as an advantage in some ways.
Yeah, that's such a great point. I definitely have seen that. So exactly what you're saying, I think sometimes either because of like stigma for sure, and also because there's sort of like this, what we found, especially with like our youth and family work, is they want to take care of each other. And so they're really hesitant to bring up things that are going to either harm the community or harm that they perceive, right, or will cause a burden. So we actually had one study where when we did our focus groups, that was like one of the biggest themes was this perceived burdensomeness. And we were really concerned about that because it's related to like suicidal ideation and things like that. But that was really strong. And so as an outsider who they're not going to burden me, you know, like in terms of there was a real eagerness to share, right? And it was a space that could be created because of that I think exactly like you said, there's benefits in that case of being an outsider with a certain approach, right? Like I wouldn't say, and so I definitely agree with you. I think that's really important. And I think also just like it helps me kind of check myself, or like when I'm getting really burnt out or kind of negative about the systems I'm in or whatever, to hear like a community partner reflect on all the value that they see, or like, wow, that's a really neat opportunity that you all get there, and kind of vice versa for like being able to really highlight strengths that are seen from that fresh perspective of like you're new and maybe in some ways kind of green, and so you're like you don't know all the politics or all the, but it offers like something that's kind of it can be a rejuvenating thing for a group that's been doing the work for a long time. Like that community violence, I mean, Kansas City has been on that for a long time, and it hasn't moved very much. And so I think there was something about that fresh energy coming in from, you know, the outside, even though I also identify Kansas City as my home. So, but I think that really is a strength that we can bring as an outsider. And our networks, I guess that's the other thing I would say, because a lot of things are also about like how do we leverage resources. So I think our networks being different can be helpful sometimes. And I'd love to learn more about your work, Ty. We have to find the time to chat.
Will do.
All right, you guys. Well, I think that takes us just to right about to 9:20. So I think that sounds like a good stop point. We've had great questions in the chat, a couple really great questions from some of your former faculty and now colleagues. So yeah, thanks so much, everybody. There's some really great comments in the chat if you want to take a look at those, Briana. And otherwise, we really appreciate you taking the time to share your research with us and share your expertise. And I hope everyone has a great rest of your Friday.
Hey, thank you all.
Take care, everyone.